all of you. Today, this monthly meeting of API, we had two important events. First is, of course, a scientific session where we'll have a talk on ALLHAT trial. And the second will be, more importantly, an installation ceremony of the new office bearers of API Executive Committee members. So, before all this, may I request all of you to kindly stand up for a silent prayer. I also need to mention that we lost one of our dear colleagues, Dr. Babu John Matthews, was a very senior consultant of Medical Trust Hospital. Let's all stand up to pay our homage to the departed soul. So for the scientific session, we had talk by Dr. Jimmy George. Dr. Jimmy, can you please come out to the dais? As an introduction, it should be mentioned that Dr. Jimmy George is the interventional cardiologist at Lisie Hospital. He is got vast experience in research, and is an academician. He's expert in a lot of international works, mainly involving hypertension and cholesterol medications like PCSK9 inhibitors. He's also involved in research on RAS blockers. May I request Dr. Jimmy to kindly start his talk.
Thank you, sir. Thank you for the kind words. I know it's a major function for API today, so I won't make my talk long. I'll try to make it as short and sweet as possible. I would thank API and IPCA for giving me an opportunity to talk about, and I would be just briefing on the old ALLHAT trial, what its impact is there in the present and maybe in the future. So basically it's an antihypertensive and lipid lowering treatment to prevent a heart attack trial, the ALLHAT, which came up in 2002, started in 1994 onwards. As you see from the past, like a lot of treatment for hypertension had been tried from the beginning of the last century, of which if you see majority in the last 50 years, mostly diuretics had taken a place after the earlier reserpine, hydrazine and alpha-methyl dopa. Slowly, spironolactone, beta blockers in the 60s, and maybe in the 60s and 70s, more of chlorothiazide and furosemide. And slowly in the late part of 80s, the calcium channel blockers and the RAS blockades in the form of ACE inhibitors, and ARB has slowly replaced or taken their own positions accordingly. Joint National Committee is the organization which classified mainly the guidelines for hypertension. It all started in the 1970s. 72 to be precise, and slowly had its own different guidelines from JNC 1 to almost 7, 8, and later taken over by the ACC, AHA in the 2018 onwards. So almost the first guideline onwards in 1977, most of the first three guidelines focused on the diastolic BP, and they were never focused on the systolic BP. And later in the late part of 80s only, the systolic BP was given an importance. Further, the combination medications or the single pill combinations came up in the early part of the last decades. So these are the few trials which were done in the past. If you see from them, I may not mention up, but I would say like in 1991, the trial was which stressed on the importance of systolic hypertension in elderly, and later the ALLHAT trial, it started in 1994 and published in 2002, gave an impact on combining medications or competing medication or newcomer medications were given a good task by the veteran medications, and that was what the ALLHAT trial was all about. So if you see from the JNC 1 to almost the JNC 7, most of this JNC classification or guidelines had diuretics, either thiazide or thiazide-like diuretics. Beta blockers had come up in the 90s or late part of 80s, but it came down as a compelling indication only. But once the ACE inhibitors, ARBs, and calcium channel blockers came in, beta blockers were slightly in the compelling medications. And the latest guidelines in the last decade had seen that all these 4 drugs, the RAS blockade, including ACE inhibitors, ARB, the calcium channel blockers, or the diuretics, especially thiazide-like diuretics, were the first line of treatment according to the age or compelling indications. Now, briefly, I will just discuss about the ALLHAT trial. So, basically, it was a drug, chlorthalidone, which was trying to compete itself and prove itself, which has already been proved drug, but it had to prove its mettle in front of strong antihypertensive medications which came in the late 90s. Those were the calcium channel blockers, ACE inhibitors, and alpha blockers. It was a trial done in the US and US islands, including Canada, almost from 1994 to 2002. A large population of almost 42,000 hypertensive patients above 55 years were involved. So the outcome trial was a hypertension outcome trial with the thiazide type diuretics, in which beta blockers were not used for this. Only when an add-on therapy was required, only was used in it. Now, this was the systolic hypertension SHEP trial design. This was also a thiazide-like chlorthalidone drug, which was randomized along with the placebo, and was seen his benefit in the late part of the 1980s. So by the time chlorthalidone had become a drug of choice as the first medications. And this is a very important slide from the 1970s to 2002. If you see that the yellow line is the diuretics and the blue line is the beta blocker, almost 60% of patients were on diuretics, and almost the remaining 30 or more than patients were on, patients were on beta blockers. But once in the beginning of the 80s, what happened, there was a sharp decline in the beta blockers, and the same sharp decline was there in the diuretics also. And slowly the calcium channel blocker, the orange one, and the ACE inhibitors in the 90s started emerging as the first line of medication. So that was the time when ALLHAT trial came, and ALLHAT trial was comparing these diuretics along with these ACE inhibitors and calcium channel blocker. ARBs had come in the later part, that was the pink one. As there was no calcium channel and ACE inhibitor trials, at that stage ALLHAT had come to prove that it is still a drug first line of treatment for hypertension. So that was the downfall of diuretics, and diuretics still was trying to make it up along with the green and the orange line. So this was basically a blinded trial which compared chlorthalidone along with amlodipine calcium channel blocker, chlorthalidone along with lisinoprolase inhibitor, and chlorthalidone along with doxazine alpha blocker. So all these 3 drugs were compared with chlorthalidone to see its response. It's 1.7:1:1:1:1 thing. So if you see the outcome of this trial, the response of diuretics was very enormous. Heart failure, you can expect it to have the maximum benefit. But not only in heart failure, but also the cardiovascular endpoints, as well as the mortality endpoints, as well as the stroke, the diuretics showed better response. The same thing was seen also when you compare with the amlodipine and chlorthalidone separately. If you see, though the BP fall in amlodipine was 2 millimeters more than the chlorthalidone, but it was only the diastolic BP which had better response with chlorthalidone. But at the same time, if you see the heart failure response with chlorothalidone was statistically significant. At the same time, if you compare the ACE inhibitor as well as the chlorothalidone, the amount of stroke, what was there, that was quite important out. There were better response or reduced stroke of almost 15% in the ACE inhibitor group had a worse stroke, so 15% better in the chlorothalidone group. And the more worst thing was alpha blocker. Alpha blocker did not have any response. All the response were in the chlorothalidone group. More of heart failure in the alpha blocker group, more of coronary event, more of stroke also. So it was prematurely stopped, the alpha blocker, and chlorothalidone had an easy sweep. Now comparing, as it was the US population, both the blacks and non-blacks were compared. And if you see, this was the time where chlorothalidone had scored over ACE inhibitor in stroke. And the response of combined cardiovascular endpoints also were better in blacks when they were given chlorothalidone compared with an ACE inhibitor. The withdrawal of drugs were almost similar in all the three groups. Maybe slight, one thing was the rise in sugar, which usually happens up, or diabetic status worsening happens slightly 2% more in the chlorothalidone compared with other two drugs. This was the same thing I was talking about. The heart failure response was better, almost 38% more response in the lisinopril group, in the chlorothalidone group compared with the amlodipine. At the same time, the doxorubicin almost had twice that response, or doxorubicin had worsening heart failure. The stroke also was better with the chlorothalidone, almost of 15% more benefit with the chlorothalidone compared with the lisinopril group. Now the heart failure treatment group also had, the yellow one was the chlorothalidone, and which had the heart failure rates the least when compared separately with the amlodipine as well as the lisinopril. At the same time, the event rates of heart failure, you can see the drastic curve difference when the chlorothalidone was compared with lisinopril and amlodipine. Those with a reduced ejection fraction also had similar response, and those with the ejection fraction more than 50% or preserved ejection fraction also had reduced heart failure rate, as the yellow says. That's comparing the mortality of almost 12% lower at 5 years when with normal ejection fraction versus the reduced ejection fraction, the violet one. This is the same thing which I was talking about, though the renal response also was better with the chlorothalidone. More was the heart failure response, the combined endpoints, and when you compare with lisinopril, the less chances of getting stroke also was there with the chlorothalidone. Majority of these patients had a combination of 1 or 2 drugs or more drugs to get the adequate BP less than 140/90. Another important thing is diuretics. What we're talking about, are all these diuretics of the same metal? Not exactly. Chlorothalidone and indapamide are the two drugs which has got the almost a D-half of more than 24 hours, and it stays for long duration, as well as the bioavailability also 90%. Now what do our new guidelines say? A fixed dose combination pill is recommended as initial therapy. So a combination therapy, either with an ACE inhibitor or ARB, especially in young people, or a combination of a calcium channel blocker or a diuretics in an elderly or more than 60 years of group. Always initiate with a fixed dose combination, if possible with the lowest dose, so that tolerable dose, and then you can easily titrate to the maximum dose or add on to a third drug, and if still uncontrolled, go with an MRI. These are the different trials which had used multiple medications, and you can see that majority of the trials had used 2 or more medications to get the adequate control. So what are the different possible combinations of the different antihypertensives available? You have the major combinations between the angiotensin receptor blocker with thiazides, with calcium channel blockers, as well as the ACE inhibitors also with the thiazides as well as calcium antagonist. but not to combine an ARB with an ACE inhibitor. And very infrequent combinations are the rest of the other dotted lines. After the 2002 release of the ALLHAT trial, the JNC7 had come with this algorithm. Those without compelling indication with stage hypertension, thiazide type diuretics are mostly used. You may consider other ACE inhibitors, ARB, beta blockers, or calcium channel blockers, or a combination. And stage 2 also, 2-drug combination, including a thiazide type diuretics. And when you have a compelling indication, you can add on beta blockers or other medications accordingly. So the different hypertension guidelines, in which the NICE guidelines had mentioned 2 thiazide-like diuretics, indapamide and chlorthalidone. Both had its own time duration of longer acting. And when you come down to the Indian guidelines, it doesn't mention, but mentions all these 3-4 diuretics, and preferably at a lower dose of 6.25 to 12.5, not a higher dose as expected in the other trials. Because you see, like hydrochlorothiazide 50 is only equivalent to 12.5 of chlorthalidone. And these are the different diuretics which were used in the different trials, and the dosage or the tolerable doses of these medications. And most of the time, chlorthalidone was 12.5 to 25, and hydrochlorothiazide was 25 to 50. So I would conclude like saying that thiazide type diuretics is the initial therapy for hypertension, and unless there's a compelling indication, those patients who cannot take diuretics, very rare patients, CCBs and ARBs or ACE inhibitors may be considered. But this trial had shown that in black hypertensive patients, where the major risk of cardiovascular endpoints are better with thiazide diuretics comparing CCB, or comparing ACE inhibitor lisinopril, but CCB can also be used as a drug of choice. And most of the hypertension patients requires more than one drug, and diuretics is generally the first line to be added to these drugs. As a movie of a trailer in the 90s in Bollywood, if you see, these were the upcoming 3 stars or the major stars. You had an ACE inhibitor, you had an CCB, you had an alpha blocker. But as time says, the mature guys sometimes does a equally or a much better work, even at their elderly stage or even at their age, because the acting what matters. In summary, I would say thiazide type diuretics, chlorthalidone in particular, was unsurpassed in this trial in preventing cardiovascular and renal complications. It had confirmed and expanded the acceptance of thiazolidone as a major treatment for hypertension. Subsequently, trials like SPRINT also had shown the benefit of diuretics in reducing the cardiovascular events, especially in heart failure. And the major trials, nationally and internationally also, as the guidelines also add on as chlorthalidone as one of the first drug of choice for treatment. Despite this, chlorthalidone remains underutilized even in poorly controlled patients, and especially in poor countries or maybe in Asian countries too. A direct comparison has been done in some of the trials, but not major one, but one is underway, which results would be out in the near future. The last slide I would conclude say that ALLHAT trial was all predictable, and there was no big surprise in this trial. As expected, nothing had come out of a hat. So as expected, this was a strong medication, and it still remained strong. Even in the 20s, when the new actors come in and take the show, you still don't know that this actor has shown his mettle in Kaun Banega Crorepati, or maybe other big things like Sarkar, which will stay on. Thank you.
And thank you, Dr. Jimmy. It's a very lucid presentation and on a very important topic, hypertension, because all of us deal in our OP daily many cases of hypertension, and the vast majority of hypertensive patients' treatment is not effective because they are not under control. There are a few things which are not very clear. First, of course, it's very good that diuretics now are approved metal, and it being one of the cheapest drugs. So the economical aspect is very good for a country like India. But then we got a lot of other hassles because firstly, India is the diabetic capital of the world. We got far too many diabetics, and thiazide diuretics in particular increases the insulin resistance firstly. And then they can also give us hyponatremia because quite often we are compelled to discontinue this drug because of hyponatremia. Then many male patients have bladder outlet obstruction because of prostatic enlargement. So that can also be adversely affected. Then lipid profile, it also is adversely affected by these thiazides. So does it really translate the same effect into our population? And second point is that you said lisinopril actually increases the heart failure in this study, but then studies like SOLD and all proved that it decreases the heart failure and improve the survival. So why these contradictions?
No, so like most of the times, like when you start on with the diuretics, these are things what comes in, right? Increases the blood sugar level, it decreases the sodium level, or it increases the dehydration. That may be the reason, like most of the times, these medications were never started as a single dose. But what was seen this in ALLHAT trial was there was almost like only a 2% difference in the increase in the blood sugar, because 35% of patients were diabetic who had come for this trial. Around 11.5% was the patients who had a new onset of rise in sugar above 126. At the same time, when you compare with amlodipine, it was just 9.8, and maybe it was 7.5, the lowest with the ACE inhibitors one. So definitely there is a rise in blood sugar, but that rise in blood sugar in a matter of 4 years, whether makes them a new onset of diabetes with this drug or with the other comorbidities, is something which we really need to know about, because a 2% rise comparing with the other two things may not be a long run, because the other medications, including the statins, also can rise in the blood sugar out anyway. The second thing, sir, was talking like ACE inhibitor is definitely one of the strong medications for heart failure, and we were not expecting to have a better response, but the cardiovascular outcomes as well as the heart failure response, and that too the heart failure response in the blacks in the US, when compared with the chlorthalidone, was better with the chlorthalidone. I don't say ACE inhibitor was bad anyway. When ACE inhibitor was compared with amlodipine, ACE inhibitor definitely would have heart failure benefit in this group out. But now when you have a single pill combination and you're planning to give an ACE inhibitor or a CCB with the diuretics or something like that anyway, then I think if we are mostly like now starting hypertensive medication as a combination medication at a low dose or an intermediate dose, then only slowly we are titrating it up. Then definitely I think thiazide or thiazide type diuretics, I would say thiazide type diuretics along with one of these ACE inhibitors or ARBs or maybe a calcium will have much better response.
See, by and large, when a diabetic patient comes to us, we start with the RAS blocker, right?
Right.
And we usually keep a diuretic as a second or third choice.
Right.
Because then we start combining as CCB, and diuretics are usually a third choice in a diabetic patients. So do you mean to say that we should now change and rather start a diuretic?
Including so our guidelines also specifically stress on ACE inhibitors ARB in young patients and even in diabetic organ. But elderly patients, the response is much more with the calcium channel blocker as well as the diuretics. So I would suggest, like, according to those things, if you're getting a young patient with diabetic, definitely don't go for a diuretic. But if you're getting an elderly patient who knows that these symptoms, because I don't think like polyuria and all these symptoms would be there for the first 2 weeks only. And when you're giving a very high dose only, all these things comes out anyway at all. And the most problem what happens is a slight fall in sodium from 134.5 to 131 or 129 will trigger the maybe trigger the local doctor as well as trigger the patient that your sodium is falling down. But I think 129 and 130 is not that a low sodium to be stopped at diuretics at that stage, because you are stopping a potent drug. You may have to think about other causes which are causing hyponatremia also.
One more question. Is the beneficial effect because of its effect on systolic blood pressure, or is it something else? Like you said, no, the chlorthalidone has got a better survival advantage as far as the end organ damage is concerned. And as far as CHF is concerned. Is it because systolic blood pressure effect?
Diuretics had more response on systolic, as well as the amlodipine had more response on the diastolic blood pressure. The fall was more in the diastolic for the amlodipine one. But whatever you see, like, so the fall in blood pressure was much more, almost it was 2 to 3 more millimeters more with the amlodipine in the final thing when you compare it with the chlorthalidone. So when you say potent drug, I think the other was a potent drug. But the change in fall in BP was marginal, only 2 or 3 only.
One last question. Doxycycline was dropped from this trial,
Yeah,
right?
prematurely stopped.
But then we are using a lot of other alpha blockers like many press, that's prazosin and all that.
Yeah.
But should we continue to use them? Because we find a lot of prescriptions
No, I think
having this alpha blocker.
the thing is like the response, the cardiovascular events were more in the alpha blocker group, as well as the heart failure was almost like double of what the heart failure was there in the other two groups. Comparing the, so I think alpha blockers may not have a role. Most of the times we give an alpha blocker only when you have a renal dysfunction, when you cannot start an RAS blockade, or you cannot give a high dose of diuretics because of the worsening creatinine. So I think that may be the only area where now alpha blockers will have a role out.
But RAS blockers are not exactly contraindicated.
It's not contraindicated, no. The only thing is like if you have a patient who is going to follow up with a creatinine, this thing, definitely you're going to start up and follow it up. But how many patients would follow up every 2 weeks or 4 weeks with a creatinine level or a potassium level is something.
Potassium may be important.
Yeah,
Creatinine
now we are
probably
starting
not.
RNE also in most of the patients. So thing is like if the patient cannot come back, because earlier we used to start in heart failure medications, one tablet as a start. Now like we started in such a way that even the dapagliflozin and beta blockers are MRA almost there in the first 1 week, and maybe in another one week time the RNA also is on the floor. So all the 4 pillars are there. By 2 or 3 weeks, patient is completely saturated with the 4 pillars, unless contraindication of BP fall, and vasodilators are withdrawn by the time.
Thank you. Questions from the audience, please.
Sir, thank you for the nice presentation. A simple question: what is the new guideline for estimation of lipids? Is it patient should be fasting or random can be done?
No, random can be done, sir, because we usually take it in random only, our lipid profile now.
Will
only
it not change the values?
values, only hypertriglyceridemia to an extent may change up, sir. But I think other values may not change much anyway at all. We
Okay, thank
definitely,
you.
because most of our patients now come after having a cup of tea, and most of the time lab people will never take lipid profile. So we
Sir,
need-
after heavy meals, it is likely to be increased.
Yeah, slightly increased only. I don't think it will be a major impact unless you have, the guidelines definitely say 12 to 15 hours of fasting out if possible out. But all the time it may not be possible, especially most of the time if the patient only wants his triglyceride to be on lower side, he fasts for 15 hours and then takes it out.
Thank you, sir.
Yes, sir.
Any further question?
All that I would like to say is that you made a very good presentation. Having been in practice for a very long time, like 5 decades, I'm glad to hear that the diuretics are coming back in full force. Having said that, the diuretics we used to use was thiazide diuretics initially. But right now the emphasis is on combination drugs. You rightfully put it across, either ACE inhibitors or AB blockers with a diuretic or a combination of calcium channel blocker, vis-a-vis a calcium channel blocker with a diuretic. And the diuretic of choice is, of course, chlorthalidone. I have not used much higher than 12.5 milligram in combination. That is my philosophy, that don't go for very high dose, don't go in for toxic levels, but always be very patient, moderate dose, add a second dose and a third dose. In a small group, a patient probably aldactone, also because hyperaldosteronism also is the order of the day when patients go in for very many years with diabetes, with hypertension. What he raised, the point of diabetes. Diabetes is definitely a very important factor. If you increase the dose of diuretics, definitely the chance of unmasking diabetes is very high, and therefore the complications would be much more.
Right.
So be very conservative, have a consensus of opinion in this. In a meeting like this, that's exactly what we want. What is the take-home message we have to take,
Exactly, sir. Like the lowest dose possible with 2 or 3 combination. That's the take, I think, what I got from you out. At the same time, like chlorthalidone, the potency is that like even a 6.25 to 12.5 is equivalent to almost a 50 mg of hydrochlorothiazide. So that difference is there anyway.
Thank you, sir.
Sir.
Diuretics. In our day-to-day clinical practice, I don't think that we have seen many of cases a diuretic-induced diabetes. They may have so many other things, but this may be one of the factors. If that is the case, we should not use rosuvastatin, because statin also can onset of diabetes. There are many drugs like that. Unnecessary concern we are putting on diuretics, a good drug, which in good hands is one of the best treatment modalities for hypertension.
And this unnecessary concern also is the hyponatremia and the excess urine
Yeah.
passage out, which I think
Exactly.
also needs to be, because
Yeah.
the patient sometimes always blames the physician for all these mistakes anyway at all. And that I think we need to educate them. We don't get time for that. That is their right, but I think it has to implement and go that way.
Exactly. So, of course, there are a lot of queries and all coming up. I think we can discuss it over dinner. Thank you very much, Dr. Jimmy, for
Thank
a
you, sir.
wonderful presentation on a very important topic which is relevant for all physicians who are practicing.